Good afternoon. It's a great pleasure to be here with you today. I would like to thank IPC for this kind invitation, Joel Gelfand for this detailed introduction, and of course all of you for being here in this awesome psoriasis symposium. My name is Angeliki Gkini. I'm a 2023 IPC fellow, and I'm going to present a patient with a comorbid solid organ malignancy. Here are my conflicts of interest. And before we start, I would just like to share how I felt when I received this invitation from IPC. So when I saw the email and the topic of my lecture, I was really excited because this topic is so hot. Why? Because cancer prevalence is rising, but on the other hand, mortality rates are dropping. So that means that we get more and more patients with a recent diagnosis of cancer, and many of these patients have also psoriatic disease. The other interesting thing is that we don't have robust data about these patients. Why? Because all these patients have been excluded from the clinical trials. So all patients with a recent diagnosis of cancer, actually during the last 5 years, are excluded from the studies. So that's why we need robust real-world data about that. Now let's move to our case presentation. So we have a 63-year-old white male. He has been diagnosed with severe psoriasis and psoriatic arthritis. He has been under our care in our specialist psoriasis clinic, and he was on secukinumab for almost 2 years and doing really, really well. In the past, he had tried many different treatments, topicals, methotrexate, cyclosporine, etanercept, and his past medical history included hypercholesterolemia and hypertension, for which he did nothing. So we need to calculate perhaps his cardiovascular risk. But otherwise, he was doing really well. Completely clear skin, almost no element of psoriatic arthritis, and he was very happy about that. So we were planning to see him back in 6 months. Nevertheless, things do not go as planned. So our specialist nurse gets an email from the patient, and the patient reports weight loss and some blood or dark blood in his stool. A red flag for me at that time. I was also a resident at that time when I was treating that patient. There was a lot of discussion at that time whether IL-17 inhibitors induce or exacerbate inflammatory bowel disease. So we just stopped the secukinumab at that time. We ordered blood tests. We ordered the fecal calprotectin, an amazing test. You know, it gives you immediately a rough idea of how things are going. Mayer test. So fecal calprotectin comes back normal. Exciting, good news, it's not IBD, but the patient is anemic, his ESR is raised, he has a positive Mayer test, so we refer him urgently to the gastroenterology MDT team and also next to the surgery MDT team. So the patient is diagnosed with an ascending colon tumor, and he is planned for an urgent laparoscopic right hemicolectomy within a week. So the first question that comes in our mind, and that's actually what the patient asked first, is whether his biologics treatment contributed to his cancer. So here you can see a copy of our follow-up sheet from BADBIR. So BADBIR is a UK national registry for patients with psoriasis on systemics. We try to enroll as many patients as possible. So when there is an adverse event, we need to reply, you know, if it's related to the drug, yes, no, or possibly. So there are many studies out there. Nevertheless, I picked up this systematic review and meta-analysis by esteemed IPC counselors who concluded that patients with psoriasis generally have a slightly increased risk for cancer, and treating patients with a biologic agent doesn't increase his or her risk of cancer. And this is also in favor of the American guidelines with an attention to comorbidities published in 2019. So all these American experts, they also concluded that there is an increased incidence in specific cancers like lymphadoepitic cancers, head and neck cancers, and digestive tract malignancies like our patient. And specific monoclonal antibody therapies do not appear to alter the malignancy risk, like the IL-17 inhibitor that our patient was on it. So the reply would be possibly no. Otherwise now, going back to our patient, the patient had his operation. He had a moderately differentiated colon adenocarcinoma, no lymph node involvement, no metastasis. That was a great scenario, I mean, for that patient. He had a test called MMR. This is related to some proteins, so then no loss of expression means good news. He doesn't need any further treatment like radiotherapy or chemotherapy, and he was under regular follow-up with surgery. In terms of us now, in terms of the skin, in terms of the joints, we just had a wait-and-see approach and see how things are moving ahead. Nevertheless, the patient, less than 3 months later, calls us. And he says, my psoriasis is really bad, my joints are awful, and I need to do something. So he has a follow-up in the joint dermatology and rheumatology clinic, and his clinical picture at that time was quite dramatic. He came in crouches, he was almost unable to walk, and his skin was quite severe, so he had a PASI of 12. And otherwise, I have a special interest in psychodermatology, so I screen all my patients about quality of life and depression and anxiety, and we can see that his scores are really, really high. So we had an extensive discussion with the patient about the various treatment options, what we could do. We just wanted to make sure that the patient understands what we're talking about, and we referred him also to the oncology and surgery MDT. The patient said to us, I don't mind if I get cancer again, I just want to get rid of my psoriasis. I don't want to have my psoriasis back. So what would you do with this patient? The first option is topicals, the second is phototherapy and acitretin, the usual suspects in such cases, but would they work for these patients? No. His psoriasis was quite severe and he had also significant joint involvement. So what did we do? We had the BAD guidelines. At that time, they were the 2018 guidelines. So we wanted to get some advice from oncology. That was a key thing. And also, there was a lot of caution whether we should prescribe a biologic agent in a patient with a very recent cancer, less than 5 years old. So at that time, we didn't have further guidance. The main guidance came from gastroenterology and rheumatology. Nevertheless, now we have this very interesting paper published last year by an expert panel, a multidisciplinary expert panel. And what did they say, these experts? So they said that if you have a previous solid malignancy and good prognosis, it doesn't matter if you start a systemic agent 1 month after your chemotherapy. It doesn't matter if you started directly after radiation therapy or directly after endocrine and targeted therapies, because the risk of cancer recurrence or progression is unlikely to be altered. On the other hand, if your prognosis is poor from the start, then you have an inherent increased risk for cancer recurrence, and therefore, whatever you do, the risk is still high. And they also suggested that no matter what the systemic agent you give, the risk for the cancer prognosis is unlikely to be altered, with a bit of caution in terms of cyclosporine. Here you can see also the different levels of support of the different statements. And also, based on the many different trials and the many available data that we have, here you can see a very nice table presenting all the different treatment options. In terms of anti-TNFs and ustekinumab, there were enough data, mainly from rheumatology and gastroenterology, and there was no increased risk of internal malignancy in this psoriasis population. Of course, advice from oncology is required. And in terms of IL-17 inhibitors and IL-23 inhibitors, because of their mechanism of action, and despite the fact that we don't have so many data, the reason is that they are more recent out there, still we don't have an increased risk of malignancy. And we have also the European guidelines, the Euroguider, who are also in favor of the previous statements with just some slight difference, again, about cyclosporine. So going now back to our patient, we restarted the secukinumab. The patient did really, really well. His skin cleared, his joints were really under good control. Nevertheless, after a few years, he got a secondary failure to secukinumab. His skin had flared mainly, not so much the joints. We had again the same process, the referral to the oncology and surgery MDT. and we switched the patient to guselkumab. Why we did that at that time? It was the time that we got the data about psoriatic arthritis and guselkumab, and we wanted also to try an IL-23 inhibitor. So now, the patient is completely clear of his cancer after 5 years. He has been discharged from oncology and surgery, and also he's doing really, really well. And as we are talking about IL-23 inhibitors, there is a lot of discussion at the moment whether blocking IL-23 could contribute to less risk of cancer. And also from some studies, some observations are that patients who are treated with IL-23 inhibitors have lower rates of malignancies compared to placebo or other active comparators. So in conclusions, biologics do not seem to be related with a higher risk for malignancy. Patients can start on conventional systemic treatment, biologics, and small molecules, of course, in a case-by-case basis. There needs to be an extensive discussion with the patient so as to make sure that he provides informed consent about starting on this agent, and the multidisciplinary approach is mandatory. Don't forget to include your patient in national registers. It's the only way to get robust, real-world data about this type of patients. And I would like to thank you very much.
Morgan, that was really a fabulous talk and a complicated subject. Maybe time for one quick question. Do you want to come to the microphone?
Margot, thank you. Great talk. Thank you very much. I want to ask you something. Now, when your patient is diagnosed with cancer, recently now we have those a lot, and we refer to the oncologist, and they say, no problem, go back to the biologics. But what do you do during the treatment? Because sometimes they really flare. What do you do about that? And it bothers them a lot. Whether if they have surgery like your patient and it's gone, that's fine. But some of them have radiotherapy or chemotherapy. Right. What do we do? And topicals don't do it.
That's true.
Yeah.
I mean, in terms of chemotherapy, sometimes what we see is that the patients do not flare up.
Yeah.
Nevertheless, there is still a percentage that flares up. I go ahead with treatment. So oncologists now are much more relaxed
yes,
too.
They are.
And
yeah.
I restart my biologic agent as soon as possible. Of course, phototherapy is a classic option when there is mainly skin involvement, and even acitretin. So generally, I would say that I kind of follow this expert consensus statement in terms of chemotherapy. Yeah. And sometimes I may start a bit earlier, actually.
Yeah. Thank you so much.
Thank you.
Yeah, you know, well, please.
Thank you.
I think, you know, the oncologists have learned a lot about our biologics over years because of immune checkpoint inhibitors. And generally speaking, they're very comfortable now with TNF inhibitors, the IL-17s, IL-23s. And so usually they're always on board. I have patients who have lymphoma that I manage with these drugs that's active. We always worry about potential progression or potential side effects in combination with chemo, but generally they've done pretty well. Shared decision-making is critical, and I really want to encourage all of you, like, these are some of the most grateful patients you'll have. I mean, the only thing worse than struggling with cancer is struggling with cancer and having severe psoriasis. It's just very isolating for people and a real way to help people.